Welcome back to the deep dive. Today we're taking a close look at the pathophysiology of type 1 diabetes.
Yeah, it's an incredibly complex topic.
It really is. And our mission today, for you listening, is to really unpack exactly what happens in your body when the insulin runs out.
Right.
We're pulling from this really fascinating stack of medical research, historical literature, and, clinical studies.
Mhm.
We want to understand how this disease went from this fatal ancient mystery to a manageable condition.
And we'll get into how cutting-edge science is finally learning to stall it in its tracks, which is just a huge breakthrough.
Definitely. But, to understand the gravity of those modern breakthroughs, you really have to grasp the sheer desperation that surrounded this condition for most of human history.
Oh, absolutely. It was a terrifying reality.
Because we usually think of medical history as starting, relatively recently. But for this, you have to go all the way back to the 2nd century CE.
Ancient Greece, right?
Yeah, ancient Greece. There was this physician named Aretaeus of Cappadocia, and he first described this terrifying wasting illness.
Right, because patients were suffering from just this unquenchable thirst.
Unquenchable thirst, constant urination, and he coined a term using the Greek word for siphon.
Siphon, yeah.
Because he felt the human body was essentially acting as a conduit, just siphoning fluids straight through itself while the flesh literally wasted away.
Wow.
And that word was diabetes.
Which is such a vivid, albeit horrific image. And for centuries, that siphon was basically a one-way ticket.
A total death sentence.
Exactly.
Right.
Before 1921, a diagnosis of what we now call type 1 diabetes was universally fatal, typically within just 1 to 2 years.
And honestly, the treatments were arguably just as agonizing as the disease itself.
They really were.
Like in the early 20th century, you had physicians like Frederick Allen and Elliot Joslin. They realized the only way to buy patients a little more time was basically through starvation.
Yeah, those brutal starvation diets.
Right. They prescribed diets that sometimes restricted children to fewer than 500 calories a day. You can look at medical archives from this era and see photographs of children reduced to skeletal frames.
It's heartbreaking to look at.
It is. And all of that was just to delay a catastrophic metabolic collapse by a few months.
Well, they were trying to manage a systemic failure without having any tools to actually stop the failure.
Right.
Because before you can reverse an escalating crisis like that, you have to understand the mechanics of the breakdown.
Okay, let's unpack this then. Let's get into the biology. For those of you listening who follow health science, the baseline is probably familiar. If we think of the human body as an engine, glucose is the fuel.
Right, the primary energy source.
But that fuel can't just passively drift into your cells. Insulin acts as the key, unlocking muscle, fat, and liver cells so glucose can actually exit the bloodstream.
Exactly. It needs to get out of the blood to be burned for energy or stored for later.
But the sources reveal a pretty terrifying mechanical brutality regarding how that key-making factory actually shuts down.
Yeah, it's a hostile takeover. So the factory itself is located in the pancreas.
Specifically within these microscopic clusters of tissue, right?
Yeah, roughly 1 million of them.
Yeah.
Called the islets of Langerhans. And inside those islets are the beta cells.
And they have one job.
One singular vital job. They are the body's exclusive producers of insulin. But in type 1 diabetes, the immune system makes a catastrophic error.
It flags them as the enemy.
Exactly. It flags the proteins on those beta cells as foreign invaders.
So it's basically a biological betrayal. Your own defense system turns into this highly coordinated attack force.
A very lethal one, yeah.
From the clinical breakdown, this involves specialized white blood cells called cytotoxic CD8 plus T cells. They essentially act as the executioners in this scenario.
They absolutely do. But they don't act alone. They're aided by CD4 plus helper T cells, and together they infiltrate the islets.
Which is a process called insulitis, right?
Right, insulitis. And once they're inside, they systematically hunt down and destroy those insulin-producing beta cells.
Now, I want to pause on the mechanism of that attack for a second because we need to clear something up. Just to confirm, this means type 1 is not caused by eating too much sugar, right?
Oh, definitively not.
Yeah.
No. That is a massive misconception. This is purely an autoimmune destruction.
Okay, good to clarify. And the research also emphasizes a lot of clinical acronyms here, things like GAD65, IA2, ZNT8, and IAA.
Yes, the autoantibodies.
Right. And if I'm reading this correctly, IAA literally stands for insulin autoantibodies. It sounds like the body is manufacturing specific weapons to kill the cells, Are they the ones doing the killing?
I'm glad you brought that up because it is a critical distinction to make. The autoantibodies are actually not the weapons.
Wait, really?
Yeah, think of them as the smoke rising from a cellular battlefield. They're just markers, the byproducts of the immune system's hyperactive state.
So they're just evidence of the crime, not the actual murderers.
Exactly. The T cells are the ones engaging in the hand-to-hand combat and destroying the beta cells. The reason autoantibodies are so heavily featured in all the literature is that they spill into the bloodstream during the attack. So for a clinician, drawing blood and finding GAD65 or IAA is an incredibly useful early warning sign.
It tells them that insulitis is actively occurring.
Precisely.
So the beta cells are dying, insulin production plummets, and the biological keys just disappear. The glucose gets locked in the bloodstream.
And it can't get to the cells that are starving for it.
Right. And the cascading effect of that is what actually kills you, because the body goes into a state of perceived starvation. The cells are screaming for energy, so the liver hits the panic button.
It initiates a backup plan. Yeah.
It starts breaking down fat at this massive, totally uncontrolled rate.
And breaking down fat that rapidly, without any insulin in the system to regulate the process, floods the bloodstream with these highly acidic byproducts.
Known as ketone bodies.
Yes, ketone bodies.
Which triggers diabetic ketoacidosis, or DKA. The blood basically becomes dangerously acidic. It's a fatal, acute metabolic crisis.
And tragically, this violent systemic cascade is still frequently how the disease is first discovered in kids today.
They just end up in the emergency room in full DKA.
Yeah, it's a terrifying experience for a family.
So curing that immediate DKA crisis was the main focus of early 20th century medicine. But treating the symptom completely obscured the underlying cause for decades, didn't it?
It really did. It put blinders on the medical community.
Let's trace that timeline, because the discovery of the treatment is practically legendary.
Oh, it's one of the greatest stories of medical history.
Right. So it's 1921 at the University of Toronto. You have a surgeon named Frederick Banting and a medical student named Charles Best,
working in the lab of physiologist J.J.R. McLeod.
Yes, and they start extracting this substance from the pancreases of dogs that actually successfully lowers blood sugar.
But the early iterations of that extract were incredibly crude.
Yeah, very rough.
When they tried injecting them into humans, they caused horrific abscesses and severe allergic reactions.
It was a terrifying failure at first. They had to bring in James Collip, a biochemist who finally figured out how to purify the pancreatic extract.
This was the missing piece of the puzzle.
And that sets the stage for January 1922. You have this 14-year-old boy named Leonard Thompson dying in a Toronto hospital, just slipping in and out of a diabetic coma.
His parents were desperate.
On January 23rd, they inject him with Collip's purified batch. And the results are miraculous. His blood sugar plummets, his symptoms vanish, and he just wakes up.
They literally pulled him back from the brink of death.
It's amazing. And Banting and McLeod win the Nobel Prize the very next year.
A prize that, by the way, generated massive historical drama.
Oh, yeah. Banting was furious.
Right. He was so outraged that Charles Best was excluded from the award that he publicly split his prize money with him.
And then McLeod, attempting to save face, split his portion with Collip.
Exactly. Lots of big egos in that lab.
For sure. But here's where it gets really interesting. The 1921 discovery proved without a doubt that this was a hormone deficiency, right? But there was this massive blind spot. Banting and his team cured the symptom, the lack of insulin. But nobody had absolutely any idea why the pancreas stopped making insulin in the first place.
Nobody did.
And that blind spot shaped the next 50 years of medicine.
It forced the medical community to categorize the disease entirely operationally.
What do you mean by operationally?
Well, throughout most of the 20th century, diabetes was defined by who got it and how it was treated.
Right.
The textbooks called it juvenile diabetes because it appeared to strike children, or they called it insulin-dependent diabetes mellitus.
Which is such a hollow categorization. It doesn't tell you anything about the mechanics of the disease.
Not a thing.
It wasn't until 1974 that the entire paradigm shifted. Two researchers in London, Gianfranco Bottazzo and Deborah Doniach, discovered those islet cell antibodies circulating in the blood of patients.
It was a massive breakthrough.
Yeah. When they published their findings in The Lancet, the medical world finally woke up to the reality that this wasn't just some pediatric metabolic issue.
It was an autoimmune disease.
Right. And that realization eventually forced a huge reclassification. By 1997, the American Diabetes Association and the World Health Organization officially dropped the old terminology.
Long overdue.
They separated the conditions into type 1 and type 2 to anchor the diagnosis in the etiology, the actual root cause, because calling it insulin dependent had always been inaccurate.
Yeah, because many type 2 patients eventually experience beta cell burnout and require insulin injections as well.
Right. So if the cause of type 1 is autoimmune, if the white blood cells are executing the beta cells, the next logical mystery is how that friendly fire gets initiated.
The underlying trigger.
The sources frame this as an intersection of genetics and environment. A lot of old textbooks use this cliche analogy that genetics load the gun and the environment pulls the trigger.
It's a bit dated.
Yeah, I think we can do better than that. It's much more like an overly sensitive algorithmic spam filter in your email inbox.
Yeah,
You know?
I like that.
The genetics write the flawed code for the filter, making it hypersensitive. But it takes a very specific, malicious email, the environmental trigger arriving in the inbox, to cause the filter to suddenly glitch and start deleting your crucial, friendly emails, which are the beta cells.
That is a highly accurate way to visualize it. The flawed code for that filter maps primarily to chromosome 6.
Chromosome 6, okay.
Yeah. Roughly half of the inherited risk for type 1 diabetes is located in a region called the HLA, the human leukocyte antigen complex.
Right. The sources mention variants known as HLA-DR3 and HLA-DR4.
Exactly. If you inherit those variants, your immune system is fundamentally predisposed to mistakenly flagging insulin-related proteins as dangerous.
The flawed code is written.
Right. But having those genes doesn't mean you automatically get the disease.
And how do we know that environment plays such a necessary role?
What's fascinating here is what we learned from twin studies. When you look at identical twins, two humans, who share essentially 100% of their DNA if one develops type 1 diabetes, the other twin only develops it about 30 to 50% of the time.
That is a staggering statistic. I mean, if it were purely genetic, the concordance rate would be 100%.
Exactly. The fact that it maxes out at 50% proves an external variable is absolutely required.
An environmental trigger is mandatory. And while science hasn't isolated a single universal culprit, certain viral infections are highly suspected, right?
Yeah, particularly the Coxsackie virus B. It's heavily suspected to be the catalyst that trips the immune system into overdrive.
But once that virus hits and the immune system glitches, you don't just wake up the next day with diabetes.
No, not at all.
Which brings us to another massive shift in how we understand the pathophysiology. In 1986, an endocrinologist named George Eisenbarth proposed that type 1 diabetes isn't a sudden, acute event.
It is a staged natural history.
Right. It is a slow burn that can take years, sometimes decades, to play out.
And Eisenbarth's staging model completely rewrote the timeline of the disease. Today, this is formalized into 3 distinct stages.
Let's break those down. Stage 1.
Stage 1 is the silent phase. The immune attack has started, the executioner T cells are infiltrating the islets, and autoantibodies are circulating in the blood. But crucially, the patient's blood sugar remains completely normal.
Because the pancreas is compensating. The remaining beta cells that haven't been destroyed yet essentially go into overdrive.
Yeah, they work twice as hard.
They hypersecrete insulin to pick up the slack, which completely masks the facts that the factory is actively burning down.
It is a remarkable biological defense mechanism, but it is ultimately finite. Eventually, the beta cell mass drops too low.
And that initiates stage 2.
Right. In stage 2, the loss is severe enough that blood sugar starts to become abnormal. It shows up in clinical tests, though the patient still doesn't feel overtly sick.
Until they hit stage 3, which is symptomatic diabetes. The beta cell mass is decimated, the classic symptoms of thirst and weight loss finally appear, and the patient reaches clinical diagnosis.
And we know this slow burn staging is a biological fact today because of the TED study.
The environmental determinants of diabetes in the young. It is this massive, ongoing international effort that followed thousands of genetically at-risk children from birth, right?
Yes. They drew blood constantly and literally watched this slow-motion process happen in real time.
It's wild.
Yeah.
They tracked the autoantibodies appearing years before the kids ever showed a single symptom. It totally validated Eisenbarth's model.
It proved that the disease we thought occurred overnight actually has this incredibly long, silent runway.
Now, having this tidy 3-stage autoimmune model for type 1 is great, and placing type 2 over in a separate category driven by insulin resistance seems clean. But is it really always this clean of a split between type 1 and type 2?
Honestly, no. Biology despises rigid boxes.
Yeah.
The deeper you weed into the clinical literature, the messier the reality gets at the edges.
Yeah, the blurred lines are where diagnostics become incredibly complicated. Take LADA, for example.
Latent autoimmune diabetes in adults.
Right. It operates on the exact same underlying mechanism as type 1, but it strikes after age 30 and progresses at a much slower rate.
Which means it is constantly misdiagnosed as type 2. Clinicians see an adult with rising blood sugar and immediately assume insulin resistance.
So they prescribe type 2 medications, which do absolutely nothing to stop the autoimmune destruction of the beta cells.
Exactly. It's giving the wrong treatment for the wrong underlying mechanism.
And then you have type 1b, which presents with all the clinical signs of type 1 total insulin loss, susceptibility to ketoacidosis. But when you test the blood, there are absolutely zero detectable autoantibodies.
It is idiopathic. We simply don't know why the beta cells die in those cases.
And MONY, maturity onset diabetes of the young. This one gets confused with type 1 because it strikes kids and teenagers, but it isn't autoimmune at all.
No, it is a distinct single-gene mutation that disrupts insulin production.
These overlapping presentations have led to some highly contested theories in the scientific community. In 2001, a pediatric endocrinologist named Terry Wilkin proposed the accelerator hypothesis.
A very controversial idea.
He argued that type 1 and type 2 might not be two fundamentally different diseases after all.
Which obviously flies in the face of the 1997 WHO reclassification we just discussed.
Total reversal.
It challenges the core dogma. Wilkins' hypothesis suggests that both conditions are essentially just beta cell failure. He argued that in children who are genetically susceptible to autoimmunity, rising obesity, and the resulting insulin resistance act as an accelerator.
Right. The extra body weight forces the beta cells to work harder to maintain balance, and that chronic stress is what allegedly provokes the immune system to attack sooner.
But I have to push back on the logic of that hypothesis.
Oh, you're not alone in that.
I mean, if Wilkin argues that obesity-driven insulin resistance is the accelerator causing the beta cell stress, how does that account for the massive number of genetically susceptible 4-year-olds who are perfectly lean, highly active, and still develop type 1?
It doesn't.
If obesity is a trigger, we would see a near 100% correlation between childhood obesity and type 1 onset in those with the HLA variants. But we don't. It feels like an oversimplification of a highly complex immune response. That is precisely the primary criticism of his work. While the hypothesis attempts to explain why the age of onset for type 1 has been dropping alongside rising childhood obesity rates, it fails to account for the lean pediatric population.
Right.
It remains a minority view, but it highlights how fluid these metabolic categories might actually be.
So what does this all mean? Parsing through all these blurred lines allows us to explicitly bust some massive misconceptions for the average person. If you take away anything from this deep dive, it should be the dismantling of these myths.
Starting with the idea that only kids get type 1 diabetes.
Yes, which is completely false. Autoimmune onset can occur at any age. We just highlighted LADA, which accounts for a massive chunk of adults initially told they have type 2, but who actually test positive for autoantibodies.
And myth number 2, family history is a reliable predictor.
Also false. Genetics set the stage, but remember the identical twin studies. The vast majority of people diagnosed with type 1 diabetes have no affected relatives whatsoever.
The environmental trigger is the wild card.
Right. Now, understanding that intricate mechanism, knowing exactly how the T cells operate and how the autoantibodies signal the attack, doesn't automatically guarantee a cure.
No, it doesn't.
In fact, trying to stop this immune assault has resulted in some pretty famous clinical failures over the decades.
Safely modulating the human immune system is incredibly difficult. In the 1980s, researchers experimented with cyclosporine, which is a heavy-duty immunosuppressant, on newly diagnosed patients.
And biologically, it did exactly what they wanted it to do, right? It preserved the remaining beta cells and reduced the patient's need for injected insulin.
It did, but the collateral damage was totally unacceptable. Broadly suppressing the immune system caused severe kidney toxicity and significantly increased the risk of cancer.
You cannot put a child on cyclosporine for the rest of their life just to save their beta cells.
Exactly.
Then there was the DPT-1 trial, the diabetes prevention trial. They tried giving oral or injected insulin to at-risk relatives to see if they could induce immune tolerance.
They were basically trying to train the immune system to recognize insulin as friendly.
But that largely failed across the overall study population.
It did. However, out of these trials came a massive silver lining in modern research, the C-peptide revelation.
Yes. Because for decades, the accepted clinical dogma was that by the time a patient reached symptomatic stage 3 diagnosis, 100% of their beta cells were just dead and gone.
Completely wiped out.
But C-peptide proves that is totally wrong. From my reading of the sources, C-peptide acts almost like a biological factory receipt.
A factory receipt, yeah.
Every time a beta cell manufactures a molecule of native insulin, a byproduct called C-peptide gets snipped off and floats into the bloodstream. So, even if a patient is injecting synthetic insulin every day just to survive, a clinician can test their blood for C-peptides to see if their own pancreas is still producing anything, right?
That is exactly how it works. And what researchers found was mind-blowing. Many patients, especially those diagnosed as adults, retain residual functioning beta cells for years, sometimes decades, after their initial diagnosis.
Which fundamentally shifts the goalposts of treatment. If the beta cells aren't all dead, it means you don't just have to replace them with synthetic insulin. You might actually be able to intervene and save the ones that are left.
And that realization brings us to the frontier of treatment today. The technological advancements are staggering. We have continuous glucose monitors sticking to the skin, reading blood sugar in real time.
We have automated delivery systems, essentially artificial pancreases, using dynamic algorithms to dose insulin automatically.
We have active clinical trials by companies like Vertex Pharmaceuticals utilizing stem cell-derived beta cell transplants. But arguably, the most significant biological breakthrough happened in November 2022.
The FDA approval of teplizumab, sold under the brand name Sealed.
It represents a monumental shift in how we approach autoimmune disease. Teplizumab is an anti-CD3 monoclonal antibody. It was tested extensively by researcher Kevin Harold and his colleagues.
And biologically, it works by binding to the CD3 receptor on the rogue T cells, right?
Yes. It effectively blinds and disarms the executioners before they can destroy the remaining beta cells. In clinical trials, it was shown to delay the onset of clinical type 1 diabetes by a median of about 2 years in high-risk individuals.
Just think about the practical impact of that. 2 more years of a child's life without constant injections, without the fear of severe hypoglycemia, letting their pancreas continue to compensate.
It is the very first drug to intervene during the silent phase of the disease.
It takes George Eisenbarth's 3-stage model from 1986 and finally weaponizes it for the patient.
Exactly. We can now use autoantibody screening to detect the disease in stage 1 or 2 and deploy a biologic drug to stall it before symptomatic stage 3 ever hits.
It is the ultimate realization of a century of scientific grind. However, we do have to ground this incredible biological progress in epidemiological reality.
We do.
Because while we are discussing algorithmic artificial pancreases and monoclonal antibodies that disarm T cells, millions of people globally are still fighting a completely different battle.
A battle for basic survival and access.
Exactly. If you look at the T1D index, which is an epidemiological modeling project tracking the global impact of the disease, their data reviews that potentially over 100,000 deaths occur every year, simply because people live in regions where reliable access to insulin is non-existent.
It is a stark, terrifying echo of the pre-1922 starvation era.
Right. The biological science is operating in the 21st century, but the supply chain and health equity for a massive portion of the global population remains stuck in the past.
And it's not just an international issue.
Even in wealthy nations, the pricing and accessibility of insulin remain highly debated structural issues. Presenting the socioeconomic data purely factually here, it is impossible to ignore that a 100-year-old scientific triumph, the discovery of insulin, is still an active crisis today.
The drug exists, the mechanics are understood, but navigating the hurdles to get it to the people who need it to live is an ongoing struggle.
It is a sobering reminder that solving the biology is really only half the battle.
It absolutely is.
So, to bring all of this together for you listening, we have journeyed from a misunderstood metabolic death sentence, treated by agonizing starvation, to the miraculous rescue of Leonard Thompson in 1921.
An incredible arc.
We explored the 1974 realization that this was an autoimmune betrayal cytotoxic T cells taking out the insulin factory. We unpacked the complex intersection of genetic spam filters and environmental triggers in the slow-burn 3-stage model.
Right.
And we looked at the modern frontier, deploying drugs to stall the disease before it ever shows a symptom.
It is a testament to the relentless nature of scientific inquiry. But it also leaves us with a really profound concept to consider moving forward.
What's that?
Well, if a drug like teplizumab can successfully delay type 1 diabetes by intervening during its silent pre-symptomatic stage? Could this three-stage framework become the ultimate template for stopping other autoimmune diseases?
Oh, wow.
Imagine utilizing autoantibody screening to catch multiple sclerosis or rheumatoid arthritis and stalling them biologically before a patient ever experiences their first symptom.
That is an incredible thought to end on. From Areteus of Cappadocia watching a disease siphon the life out of his patients, to a future where we might be able to turn off the biological tap before a single drop is lost. Thank you for joining us on this deep dive. Keep asking questions, keep challenging your assumptions, and we'll see you next time.